ang kaya lang niya i-discuss kung ano nakikita niya. Hindi naman nakikita yung ano yung histopath eh. Kasi wala pang microscope noon eh, no? Ngayon, nung dumating yung isa sa mga students niya, si Rufus of Ephesus. Rufus, wala silang apelyido eh. Ano yan? 70 AD to 110 AD. Ano, several hundred years pala pagkatapos niya. Marami na. Siya yung isang unang gumawa ng detailed description of the pancreas. Ilagay niya sa libro niya kung paano yung mga ducts, pancreatic duct, yung blood supply, arteries, veins, yan. Si Rufus Ephesus yun. Alam lang nila merong secretion yung pancreas na nagpupunta sa gastrointestinal tract. Ngayon, it was almost gaano katagal? Close to 1 century, no? More than 1 century. Bago na invento yung microscope. Nung na-invento na yung microscope, nakikita na nila yung maliit na cells. At isa sa gumagamit ng mga microscopes si Paul Langerhans who is a German pathologist, and he first noted yung distinct different cells, no, sa pancreatic tissue, which is not like the ductal cells. Pero yung German doctor, yung nag-name niya na islets of Langerhans is a French doctor, hindi si Paul Langerhans. Patay na siya nung tinawag yan na islets of Langerhans. Pero hindi naman siya marunong mag-stain eh. Kaya ang tingin lang niya, there are different cells in the pancreas, no? They are different from the ductal cells. Yun na sinabi niya. Akala nga niya lymphoid tissue. Akala niya part yan ng lymphatics for immunity. But later on, no, nung dumating yung mga magagaling sa sa pag-i-stain, no? Oops. Ay, pagka ganito pa lang walang animation Anyway, si Michael Lane, no? Siya ang isa sa mga nagsimula mag-stain ng iba't ibang tissues. At nung in-stain niya yung islets, nakita niya na iba't ibang cells pala meron sa islets. Kaya na-describe niya that in the islet cells, there are alpha cells, beta cells. Later on na nila nakita na may iba pang cells. Kaya nagkaroon ng delta cells, PP cells, nag-iba-iba pa. Hindi naman biglaan nakita yan eh. Unti-unti nilang na-discover lahat yan. Until the time, no, na unti-unti nila na-associate yung pancreas dun sa diabetes. At nung hinahanap na nila yung function ng pancreas para sa diabetes, no, it was in Toronto. Doon nila na-prove na yung pancreatic secretion talaga nakakatreat ng ketoacidosis, yung diabetes coma. Doon nila sila Banting and Besnet. Napag-usapan natin, palagay ko, sa mga kwento-kwentuhan natin kabisado nyo na yan. Pero syempre, nung ginagawa nila yung extract para ibigay sa iba't ibang mga pasyente may diabetes, pinupurify nila yan tinatanggal nila yung mga impurities. No? 1 year later, kasi 1991 nung ma-discover yung insulin Yung 1922, the following year, isa sa mga mahilig mag-purify ng insulin, alam na niyang may maraming impurities yan. At isa sa mga impurities niyan, no, may sariling action. And a few years later, no, in studies, yung mga mga kasamahan niya, si Kimball and Marlin, na-isolate nila yung impurity na yon. Na pag binigay mo sa animals, tumataas ang blood sugar. Kaya tinawag nila at that time, glucose agonist. Glucose agonist. Pero sinorkat nila. Haba ng glucose agonist. Ginawa nila glucagon. At yung glucagon na yon, hindi pa nila alam kung saan nanggagaling. Hindi nila alam kung anong cell ang nagpo-produce ng insulin Alam lang nila, nanggagaling yan sa pancreas. Ganda ng maganda yung history, no? Ngayon, after a few more years, almost 10 years nga eh, gumaling sila sa staining, no? Sa staining ng iba't ibang tissues. At nung in-stain nila, yung islets of Langerhans, gawa yan ni Dr. Bloom, diyan nakita nila yung very, very sophisticated arrangement ng cells dun sa islets. May alpha cell, may beta cell, may delta cell, mayroong PP cell, at nandun sila sa iba't ibang places nung islets. At certain areas nandun din yung blood vessels. Ang ganda ng pagkakaano nila eh. Ng story nila eh, no? Now, a few years more, si Gomori gumawa ng magandang tawag dito, magandang test. Kasi marunong din sila mag-stain eh. Alam na nila kung paano i-stain yung mga yung iba't ibang mga molecules. Ito, ini-stain niya ngayon yung insulin. Gumawa siya ng stain na didikit sa insulin. Kaya yung rats, na binigyan niya ng stain niya, nakita niya, ay nandun pala sa cell na beta cell, nandun pala yung insulin. Ayan, sabi niya. And after a few decades, nagkaroon ng study, no? Na pagka binigyan mo pala ng sulfonylurea yung daga, no? At kinunan mo siya ng pancreatic biopsy, tinignan mo yung islet cells, nawawala yung insulin sa beta cell. Kaya nakita, nasa yung pala ni-stimulate ng sulfonylurea yung beta cell na mag-release ng insulin. Kaya dahan-dahan yung mga information na dumadating eh. Hindi rin biglaan eh, no? And later on, isa sa mga sikat na na metabolist, si Dr. Sutherland, siya isa talagang gumawa ng very extensive study on the alpha cell and glucose metabolism. Sa kanya natuto sila Unger, yung mga sumusunod na, ang dami nang sumunod sa kanya na very, very passionate ang kanilang interest sa alpha cell. Nakita niya ng effects ng glucagon pala ay marami. Sa metabolism, glucose metabolism, lipid metabolism, protein metabolism, energy, lahat yan may effect yan. At yan pag-uusapan natin dun sa mga main events sa mga lecture series natin. A few years more, no? Si Bromer, ang pinakamagandang ginawa niya, na-sequence niya yung glucagon, no? Nakuha niya yung sequence ng amino acids sa glucagon. Kaya naaral na nila yung glucagon sequence. At nung inaaral nila yan, nakita nila na yung palang secretion ng glucagon is very, very systematic, no? Kasama na diyan si Grimbel, no? Grimbel. Pagka ginawa pala ng alpha cell yan, pro-glucagon. Ang habang protein yan, mahabang protein yan, no? And depending upon the cell, no? Pagka pancreatic alpha cell, pag yun ang gumawa ng pro-glucagon, nagiging glucagon yan eh. At certain points of the blood of the long protein, nagiging glucagon na po-produce. Kaya iba naman, iba't ibang fragments. Pero depende yan kung saan portion ng malhabang amino acid na puputol. Kasi sa intestinal K cells at saka L cells, no? Sa ibang portion siya napuputol eh. Kaya hindi siya nagiging glucagon, nagiging glycentin siya or nagiging oxyntomodulin. Pag-usapan natin next time yan. May kanya-kanyang function yan. No? At ito nga sa L cells, A cells, no? L cells, nagiging GLP-1 siya. At yung isang fragment pa, nagiging GLP-2. At lahat yan, iisang protein ang pinanggagalingan. Pro-glucagon yan. Kaya nga tawag dito, di ba? Glucagon-like polypeptide 1, glucagon-like polypeptide 2, kasi nanggagaling sila sa isang mother protein. Isang mother protein lang yan. So, unti-unti nila na-discover yan, hindi biglaan. Kaya yan ang istorya ng paano na-discover isa yung function ng alpha cell. Ngayon, alam na, dahil sa protein siya at ginagawa siya siyempre, ng genes, na-identify na rin kung saang chromosome nang gagaling yan. Huwag nyo nang hulaan kasi eto na nasa slide na Nasa chromosome number 2 sa humans. Sa mga daga, ibang chromosome number nanggagaling yung proglucagon peptide. Pero sa humans, sa chromosome 2. Yan pa yung band At saka kung saan nucleic acid nagsisimula, anong number at saan nag-i-stop. Very, very intelligent na sila ngayon. Ang dami na nilang nalalaman sa genetics. Itong slide na to, kukwentuhan man lang tayo, no? Ito ay ine-emphasize kung ano nangyayari dun sa proglucagon na ginagawa ng alpha cell at saka ng iba't ibang cells. So, pagka sa islets, alpha cells, ginawa yung proglucagon, ang main product yan glucagon. Konti lang yung ibang fragments. Pero pagka nangyari, ang cell endocrine cells, yung L cells, K cells, no? Mainly nagagawa dyan yung GLP-1 saka GLP-2. Medyo lumalalim tayo. Next time pag-uusapan natin yung mga functions na. Hanggang doon lang muna tayo ngayon. Kasi marami pa tayong ibang pag-uusapan. Kung meron kayong mga gustong itanong, isulat nyo lahat yan. Magtatanungan tayo. Mag-unmute lang kayo at guloy nyo ako. Meron pa tayong something like 5 minutes para magkwentuhan. Kung wala kayong tanong, merong ipapakita si Kuya Danny.
Maraming salamat po, Kuya Elwin. Napaka brief and clear naman sa ating lahat kung nasaan nanggaling kung gaano ka-importante itong discovery ng glucagon bukod sa discovery rin ng insulin natin. So, sabi nga, it goes hand in hand yung isa, meron din ka-partner. Okay? So, kung wala pong tanong, doon tayong hiningi sa inyo na mga video tungkol sa ating bakuna. Kasi di ba last year, ang napag-usapan natin during COVID. So ngayon dumating na yung bakuna. So papakita namin sa inyo yung ating
advocacy.
Final product. Ito yung advocacy ng PSD para ma-share nyo rin po sa inyong mga friends, sa inyong mga Facebook account, sa iba pang yung mga social media accounts. Okay? So, panoorin po natin. Sana po ay magustuhan niyo.
Ako po si Dr. Agnes Cruz.
Ako po si Dr. Celestra ng Rizal.
Ako po si Dr. Dean Fajardo.
Ako si Dr. Eden Castillo Cariñal ng Batangas City.
Ako po si Dr. Joy Abigail Hernandez ng Santo Tomas, Batangas.
Ako po si Dr. Cynthia Sanchez ng San Pablo City.
Ako po si Dr. Domingo ng Caloocan City.
Ako po si Dr. Rosel Pozo ng Pasay City.
Ako ni Dr. Jojo Tan, Katbalogan Sama.
Maayong hapon kaninyong tanan. Ako si Dr. Marisa Garcia, gikan sa Cebu.
Ako po si Dr. Jaylin Javier Agra ng Lopez, Quezon.
Ako si Dr. Marcy Cruz.
Assalamualaikum. Buenos dias a todos. Ako po si Dr. Fatma Ibatio.
And Dr. Danny Baldimor.
Ako po si Dr. Frances Solidan Quebec ng Parañaque City.
Ako po si Dr. Jelina Santos ng Quezon City.
Gumagamot po ako ng mga pasyenteng may diabetes.
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 Gumagamot ng pasyenteng may diabetes.
Ako po ay gumagamot ng mga taong may diabetes.
Ako po'y gumagamot ng pasyenteng may diabetes.
Ako po ay nanggagamot ng mga taong may diabetes.
Gumagamot po ako ng diabetikong pasyente.
Nagbubulong ako in mga pasyente nga may diabetes.
Nagatambal ko sa mga pasyente na dunay diabetes.
Gumagamot ng pasyente may sakit na diabetes.
Gumagamot ng mga taong may sakit na diabetes.
I see and treat patients with diabetes.
Mutambal ko og mga pasyente nga naay diabetes.
Gumagamot po ako ng mga pasyente may diabetes.
Magpapabakuna po ako laban dito sa COVID-19.
Magpabakuna ko kontra COVID-19.
Magpapabakuna ako laban sa COVID-19. Sana kayo din.
At magpapabakuna po ako laban sa COVID-19.
Magpapabakuna po ako laban sa COVID-19.
Handang-handa na po magpabakuna against COVID-19.
At handa na akong magpabakuna laban sa COVID.
Magpapabakuna po ako laban sa COVID-19.
Magpapabakuna po ako laban sa COVID-19.
Magpapabakuna po ako laban sa COVID-19.
At ako ay magpapabakuna laban sa COVID-19.
Magpapabakuna po ako laban sa COVID-19.
Magpapabakuna ako kontra COVID-19.
Musugot ko mo pabakuna sa COVID-19.
Ako ay magpapabakuna laban sa COVID-19.
Magpapabakuna ako laban sa COVID-19.
I will get my vaccine against COVID-19.
Ako po si Dr. Fernando ng Quezon City. Gumagamot po ako ng mga pasyenteng may diabetes. Magpapabakuna po ako laban sa COVID-19. Thank you, Danny.
Thank you po, sir. Thank you sa lahat ng mga doktor na nag-participate. At thank you din po sa nag-arrange nitong video sa Sir Larry ng Gets Pharma. Okay? So, bibigyan namin kayo ng kopya para ma-share po ninyo para mabawasan yung agam-agam ng ating mga frontliners at saka yung mga pasyente.
Sir Danny.
Po, sir.
Request tayo sa kanilang isa pang ganun. Kasi hindi yung iba hindi nakapaghahabol ng video eh. Request pa tayo sa kanila. Iba naman ang sasabihin. Mas madali. Ako si Doktor so and so, nabakunahan na ako laban sa COVID-19.
Yeah.
Yan, hingan natin ng video yung mga nabakunahan na.
Oh, siguro sir, maganda i-disclose natin na si Dr. Elwin po nagkaroon ng COVID-19. At nung isang araw po ba, ay nagpabaksin na rin siya ng COVID-19. Okay?
Last year ako nagka-COVID.
Last year. So, kailangan 90 days after ka magkaroon ng infection, pwede ka nang magpabaksin. Okay? So, yung mga iba po natin mga kasama o kakilala, pwede naman silang magpabaksin. Ako naman, nakaschedule na sa March 9. Bakuna. So, pagka natapos din po kayo, gagawa din po tayo ng video. So, yung name, tapos na sasabihin natin po na nabakunahan na tayo. Okay?
5 seconds lang yun.
Oo nga. Kaya mas madami po yung mga hindi pa po nakapag-submit dito. Alam ko, inuuna ngayon na bakunahan yung ating mga government, hospitals, dito sa Maynila, sa mga big cities. And now, papunta na sa mga provincial hospitals. So, get ready. Sana nagpalista po kayo para mabigyan na nila kayo ng vaccine. Okay? So, we'll gather that. So, most likely, baka next week, makabuo tayo uli ng isang bagong video. So, hintayin namin po na ma-roll out sa inyo yan. Okay? So, tuloy-tuloy na po tayo. So, ang next natin na papakinggan ay isang lecture. Okay? Mula sa ating pharmaceutical partner for this evening. This lecture is a pharmacy ME grant from Merck, the makers of Glucophage XR, Glucovance, and Invocana. Siguro yung iba po sa inyo nagulat din, no? Nasa kanila na ang Invocana. And to share with us some thoughts, may we call Miss Genesa. Okay, sorry. Miss Genesa Marcelino, the Assistant Product Manager of Merck, for a few words. Welcome, Miss Genesa.
Good evening po, other doctors.
Yes, ma'am, we hear you.
Okay, sorry po. Good evening, dear doctors. I am Junessa Marie Marcelino, the Assistant Product Manager of Merck for Diabetes franchise. First of all, we would like to thank you for being here with us tonight, and special thanks to the Philippine Society of Diabetologists for the opportunity of partnership with them. And special thanks as well to Dr. Elvin Fernando for being our speaker and for sharing his knowledge and expertise with us this evening. Doctors, thank you din po sa support nyo for Merck Diabetes products such as Glucofage XR 500, 750, and 1 gram, and Glucovance 500/5 and Glucovance 500/2.5. To add, Doctor, Merck and Johnson & Johnson has entered into an exclusive partnership. So starting March 1 po, Merck will be the one to promote the SGLT2 inhibitor brand Invocana, available in 100 milligrams and 300 milligrams. We hope, doctors, that you give the same support that you've given to Glucofage XR and Glucovance to Invocana. God bless po, doctors, and stay safe po. Maraming salamat.
Thank you, Ma'am Janessa, for this support to PSD. So wag na natin patagalin. Ito po ang lecture ni Kuya Elvin, ang ating President. Okay.
Nahanap ko yung lecture ko eh. Hindi ko makita. Ayan, nakita ko na. Talaga naman. Kasi, matanda na kasi talaga. Matanda na talaga. Yun.
Hindi pa sir, senior ka lang.
Senior lang ba? Thank you sa Mark, ha? Thank you for being with us. And
maraming salamat.
Thank you for your support. We are going to talk about molecules that are being marketed by Merck. And they can be used for preventing and treating type 2 diabetes. Kaya yan ang title natin, yan ang pagkwentuhan naman natin doon sa portion na to. No? So, in the next few minutes, no, we're going to use the slide module of Merck. Prepare nila to, no? But do not forget that whenever we talk about different products, we always advocate the highest possible standards of care for the people that we treat. And those are people with type 2 diabetes. So we're going to talk about metformin and type 2 diabetes prevention in pre-diabetes population. Yan yung mga pasyente overweight, obese, previous gestational diabetes, Asian patients, yan ang usapan natin ng konti. Tapos, pag-usapan din natin ng briefly, yung role nung naiiwan na sulfonylureas pa. Ang dami pa natin sulfonylureas dito. Yung mga bata hindi na marunong gumamit eh. Pero nandiyan pa rin sila in the treatment of type 2 diabetes, and it is beneficial also when it is prepared as a fixed dose combination. Kaya pag-usapan natin yan. Ngayon, may lumalabas sa akin kung ano-ano dito, hindi ko naintindihan. Teka muna. Yan lang natin, ha? Sana hindi magulo sa inyo, sa akin lang magulo. Yan, natanggal ko na yung gulo.
Okay na, sir.
Okay na dyan? Sige.
Apo.
Kaya pag-usapan natin isang case muna. No? Isang case na siguro, tuloy-tuloy na yan. Yung 38-year-old Filipina, no, na may past history ng gestational diabetes, maraming anak, may pangit ang OB history, family history positive for diabetes. Parents, grandparents, tapos sedentary lifestyle, 5 hours a day. Daig tayo niyan. 5 hours a day ang TV. Ang BMI is 25, o alam niyo na overweight yon, sa waist circumference din, at saka merong acanthosis nigricans, may insulin resistance pa rin. Ano pa yung isang tanong na gusto natin sagutin dyan? Ano ba yung mga factors that will put this patient at risk for developing diabetes? At saka paano ba natin siyang screen? Now, you will see is a list of all the risk factors na nakita nung Unite Philippines for diabetes. And encircled in red are the ones that we see in our patient. Meron siyang GDM, meron siyang sedentary lifestyle, positive history of diabetes. Yan ang mga may strength of association. Hindi siya previously identified IGT, pero siya GDM. Wala naman siyang PCOS, cardiovascular disease, pero mga risk factors din yan eh. Because may iba pang risk factors eh, schizophrenia, pero hindi naman schizophrenia pasyente, yun, acanthosis nigricans, siya ay overweight, hindi naman siya hypertensive or dyslipidemia. Pero kita nyo, that for every risk factors, there are different strengths of association. And if you look for if you list all the factors, you see here GDM, family history, sedentary lifestyle, and if you look at which factor has the highest risk of developing diabetes, that is gestational diabetes. Yan ang pinakamataas eh. Relative risk of 7.43. Kaya yung mga nagkaroon ng history of gestational diabetes, babantayan nyo sila. So going back to our case study, how are we going to screen this patient? Marami siyang risk factors. Ang ginawa ng attending niya dito ay ginawan siya ng FBS, which is correct. 103 ang lumabas, 2 hour post-glucose blood sugar, pinainom siya ng 75 grams of glucose, as 2 hours later, kinunan siya ng blood sugar, at ang nakuha ay 155. So here, we know talaga meron siyang impaired glucose tolerance, pati nga impaired fasting glycemia. Meron din. And you can check that against the normal blood sugar levels during the fasting state or after being given a challenge. Kaya ito ngayon ang criteria for impaired fasting and impaired glucose tolerance which our patient fulfilled. Hindi ko naiisa-isahin yan, knowing PSD ay kabisadong-kabisado na yan. So what is the natural course of this glycemia in pregnancy? Bakit ba mataas yung risk? Ano ba yung na-observe nila? Pinag-aralan sa PGH yan eh. About a decade ago, they took more than 1,000 patients with GDM. And among Filipino GDM patients, they were able to conclude that the incidence of postpartum glucose intolerance is high. 7.3% diabetes. May diabetes na pala, pagkatapos yung IGT, IFG, 34.7%, more than a third. And this risk of developing postpartum glucose intolerance is increased with postpartum obesity and the earlier onset of GDM during pregnancy. So this is a Philippine study. So we try to answer another question, the next question. What is the natural course naman of IGT, impaired glycemia, in the population? This is published in Diabetes Care, and out of thousands of patients with IGT, they were able to observe that 25% only revert back to normal. 1/4 lang ang nagpunta sa normal. three-fourths hindi na babalik sa normal, no? One half, 50% become persistently pre-diabetic. Pero a large one-fourth, no, becomes overtly diabetes. And the risk for developing cardiovascular complications is present in patients who develop diabetes and those who have persistent pre-diabetes. They have high risk for the complications. Kaya ayaw natin na magtuloy-tuloy yung kanilang ng dysglycemia. So are there evidence supporting medical treatment on top of lifestyle management?
Sir Larry, naghang si Doc.
Opo, Dr. Danny. Stop share ko muna yung kay Doktor.
Oo, naputo lang connection ni Sir.
Opo.
Oo.
Pati yung naghang din.
Sino ba? Tayong lahat?
Opo, yung kay Dr. Elwin. Though yung sinishare niya, naghang din. Walang yan. Yan.
Yan baka
Alam
na
sir, na naghang siya.
Oo, nag-restart siguro siya ngayon. Hindi pakitawagan nga si Sir.
Oo, baka mamaya nagle-lecture pa siya.
Oo, hindi niya alam na wala.
Ayan, nagle-lecture pa rin siya.
Saan mo nakikita? So habang hinihintay natin siya bumalik, maraming salamat ulit sa mga nagpadala ng videos. So sana po maka-join kayo sa susunod nating MTV. Andiyan na po si Dr. Ang.
O, Danny, kung matatagalan si Doktor, pagbalik ta rin natin.
Oo nga. Kung Sir Larry, habang inaayos ni Sir, si
Doc Danny?
Dr. Ang naman. Yes.
Proceed daw po muna kay Dr. Ang.
Sige, ito na. Sige. So, again, we will go back later sa lecture ni Kuya. So let's proceed first with a very wonderful, interesting, and lecture, okay, on alpha cell. So our speaker is our past president ng Philippine Society of Diabetology and also a faculty and the head of research unit of ISDFI. Okay, he is an active consultant of Cardinal Santos Medical Center and Pasay City General Hospital. Okay, so let's hear the lecture of Dr. Ang on the alpha cell.
Okay, so as an introduction to the alpha cell course, we're going to discuss the role of alpha cell in pathogenesis of diabetes. So the discussion will center on the dysfunction of the alpha cells, which is the missing link or missing mechanism.
Sir Larry, wala audio niyo.
Lin, ako mag-share pa. I-share na lang.
As an introduction to the alpha cell course, we gonna discuss the role of alpha cell in the pathogenesis of diabetes. So the discussion will center on the dysfunction of the alpha cells, which is the missing link or missing mechanism in the pathogenesis of diabetes that has been forgotten, uh, but not lost. I will try to elaborate on this as we go on with the succeeding slides. So this is the cartoon pictures of the different islet cells and their arrangement. Um, as you all know, islets of Langerhans was discovered by four Langerhans in 1869, and the cytoarchitectures of the human islet were most of most of it is composed of the beta cells. It's about 71%, which shows association with other endocrine cells, suggests unique parakine reaction. The alpha cells, as you can see there, is our interest in this course. Beta and the delta cells as represented in the cartoons. Other islet cells which are not shown are the PP cells or the pancreatic polypeptide, the gamma, sometimes called the gamma and the F cells. And the last one is the epsilon, the last that was discovered, which secrete gremlin. Now, let me just emphasize in that in the mouse islets, there's a little difference with human. The alpha cells are within the mantle in the outer border of the islets in the mouse islets. However, in human islets, the alpha and beta cells are mixed all throughout in the islets. So the history of glucagon begins with that of the discovery of insulin in 1921, as you all know, when Banting and Bess tested their first pancreatic extract in a pancreatectomized dog. Okay, this is the name of the dog, Marjorie. They observed that the insulin-induced lowering of blood glucose was preceded by a brief hyperglycemia before glucose was lowered. And they thought at that time it was just due to epinephrine. Okay, they didn't bother to look for the reason and continue to discover successfully the first exogenous, which is the crude insulin, that have helped and saved the lives of tens and thousands of type 1 diabetes. And in 1923, Banting and Bess went on to receive the Nobel Prize for their work. Now, however, it was John Merlin together with Charles Gimbel were the one who discovered the impurity in the early preparation of insulin. They call it a toxic fraction causing a rise in blood glucose. So they coined the term glucagon from the two-word glucose agonist. However, it took a further 25 years before Sutherland and the Dube established that glucagon is released from the alpha cells. And the identification of amino acid sequence of glucagon and the development of radioimmunoassay, a very sensitive glucagon test by Yalo and Berson, made it possible to quantify glucagon that paved the path for a more complete understanding of its role in physiology as well as in disease. Meanwhile, the contaminant stigma persisted among rank-and-file physicians, stigmatized for being largely diabetogenic in nature, with metabolic actions such as glycogenolytic, gluconeogenic, and ketogenic activities. And because of these reasons,
glucagon was just relegated for the treatment of severe hypoglycemia shortly after sequencing and purification. The initial lyophilized glucagon that need to be reconstituted on your left uh, was quite inconvenient to use, especially in severe hypoglycemia. Uh, they developed an emergency kit wherein the reconstituted fluid is already in one kit. It makes it a little more convenient. However, in 2019, FDA had approved the first nasal glucagon powder for severe hypoglycemia that is delivered by as a dry powder spray in a portable single-use ready-to-use device. All of these are available in the States. Okay, glucagon, the pleiotropic hormones. Identification of a sequencing the 29 amino acids of glucagon, together with the discovery of a sensitive test, radioimmunoassay, have led to the understanding of these pleiotropic hormones or effect of glucagon, the effect beyond glucose homeostasis. Emerging evidence suggests that glucagon regulates a range of metabolic action, including lipolysis, ketogenesis, fatty acid oxidation, increase in satiety, and in decrease in food intake, uh, effect on thermogenesis and energy expenditure, and even bile acid metabolism. This glucagon-mediated improvement in lipid and energy metabolism may be quite desirable in patients with metabolic syndrome. Glucagon action and its signaling pathways was an area of previously underappreciated clinical importance. And with this new information, it paved the way to the renewed interest in the biology of glucagon and cellular aspect of glucagon secretion and action to those extending the concept of physiology and pathophysiology of the hormones from the experimental animals to human. Now, going back to insulin, the discovery of insulin was acclaimed as the greatest achievement in medical history and won a Nobel Prize within 1 year of its first injection into human. Since then, insulin has been considered the single most important metabolic regulator, and the catabolic derangement of type 1 diabetes have been directly attributed to insulin lack. The so-called insulocentric view of diabetes, and this has persisted for 99 years. Then in 1973, Roger Unger and Lelio Orsi of Geneva proposed the bihormonal abnormality hypothesis of diabetes, stating that glucagon elevation was as important as insulin deficiency, and glucagon was misjudged as an important pancreatic extract impurity, and glucagon was forgotten but was not gone. So in 1975, in his Bunting Memorial Lecture, Roger Unger presented evidence that elevated glucagon as the regulatory partners of insulin, the so-called bihormonal abnormality. However, the importance of glucagon in a normal glucose homeostasis and in a diabetic phenotype remain controversial. Clearly, the vast majority of clinicians and scientists continued to believe that insulin did it all and that glucagon had at most a relative minor role. Even today, they say even more few scientists or clinicians accept the glucagonocentric premise that the alpha cell dysfunction is the sine qua non of the diabetic phenotype and that its correction independent of insulin treatment would provide important therapeutic benefit, as suggested by Unger et al. In 2012. The sine qua non, which means without it, it isn't. Without glucagon, no hyperglycemia, even in the absolute lack of insulin. So here's the changing concept or the changing dogma of diabetes. In 1922, the discovery of insulin, it was believed that lack of insulin is the key pathogenesis of type 1 DM, and giving exogenous insulin will solve all the problems of type 1 because lack of insulin leads to decrease in glucose utilization, increased lipolysis, increased proteolysis, increased hepatic glycogenolysis, increased ketogenesis, and decreased glycogen synthesis. In 1975, starting to recognize the role of glucagon since the different diabetes abnormality are caused by lack of insulin or by excess glucagon, the so-called bihormonal concept. In 2011, more emphasis on glucagon this time, and the premise is that lack of insulin directly causes some diabetes abnormalities, and insulin lack also leads to glucagon excess, which in turn causes other symptoms. Okay, so the so-called glucagonocentric. More emphasis now on glucagon. Now, these are the pictures of selected scientists with major contributions in the research of glucose metabolism, starting from Paul Langerhans, okay, and the last one was the last picture is Roger Unger, who gave us the concept of glucagonocentric view, the importance of glucagon in diabetes. As you can notice, all but Roger Unger has years of birth and death. The last photo of Roger Unger was still very active, even very active in 2019. Roger Unger, who pioneered the concept of glucagon view, an endocrinologist who have contributed so much in the understanding of diabetes. He was born on March 7, 1924 in New York City, New York, USA, but passed away last August 22, 2020. Okay, so this was his work, the glucanocentric restructuring of diabetes. Okay. Here, they propose glucagon excess rather than insulin deficiency is the sine qua non of diabetes, and these are based on the following evidence. Number one, the glucagon increases hepatic glucose and ketone production, catabolic features present in insulin deficiency. Number two, hyperglucagonemia is present in every form of poorly controlled diabetes. Number three, glucagon suppressors like leptin and somatostatin suppress all the catabolic manifestations of diabetes during total insulin deficiency. Number four, total beta cell destruction in a knockout glucagon receptor knockout mice does not cause diabetes. And number five, perfusion of normal pancreas with anti-insulin serum causes marked hyperglycemia. So my task is to share with you the original work of Unger and colleagues based on these premises or evidences. Now, first, the study in animal model, wherein both mice completely depleted with beta cells without any detectable insulin and C-peptide in the circulation. Okay, the mouse on your right, okay, is obviously very sick with severe polyuria. As you can see, the ground was so wet with urine. Both of them carries or wear a pump. Okay, on the right, the pump contains just a buffered saline. On the left, the pump contains a glucagon suppressor to suppress glucagon effect. Okay. So, the result on your right, the sick animal, because of lack of insulin, there's a marked hyperglucagonemia because of unsuppressed glucagon, remember this mouse pump contains only saline. While on the left, who carries or the pump contains a glucagon suppression showed a normal level of glucagon. So it appears that insulin lack is not essential for the development of diabetes symptoms. This difference was so remarkable that they explored this in further detail. Now, the study with a knockout mice or glucagon receptor knockout mice, on these mice, they measured both the glucose and the messenger RNA of glucagon receptor for the presence of glucagon receptor. So here, when they destroy all the beta cells by injecting streptozotocin injection, they use a double dose of SDC just to ensure all beta cells are destroyed. It shows no increase in glucose despite of no insulin from the destroyed beta cell, and so you can see total zero glucagon receptor messenger in the red box. Okay, and then you see the role of glucagon when they gave an adenovirus containing glucagon receptor injection back, and within 2 days there was a peak level of very high level and expression of glucagon receptor messenger RNA, but was only transient, which is usually the case. And you see eventually the expression drop off and disappear. And during the rise in the expression of glucagon receptor, hyperglycemia occurs, reaching to about 500 milligrams per deciliter before it went down to normal glycemia after the messenger RNA was no longer detectable. Now, this animal experiment do suggest that what caused the syndrome of type 1 DM metabolic consequences was not the lack of insulin directly, but instead the unopposed action of glucagon when insulin is absent. Now, this is the topographic scheme of normal human islets showing a unique or a spatial arrangements of alpha and beta cell, which is extensive juxtaposition of beta cell in red and alpha cell in green that facilitates instantaneous insulin control of the glucagon secretion via the interstitial space separating the two cells, a very special paracrine effect. Now, to better understand this is to look at the interaction of islet cells in vivo in human. Normally, every beta cells are practically juxtaposed with alpha cells. And when you look at type 1 on your left, type 1 DM, obviously all beta cells are destroyed and the alpha cell sits in the islet themselves unopposed. The question is, what is the importance of this juxtaposition of the islet cells? That does it have functional implication or just by accident? And the answer is it has a vital implication in glucose homeostasis. This close proximity permits insulin to tightly regulate glucagon secretion and precisely control the insulin-glucagon ratio in healthy pancreatic islets. Now, here we look at the important paracrine effect in healthy pancreas in the islet isolate. When perfused with 5 millimolar of glucose, the beta cell secrete low level of insulin. This level does not suppress alpha cells. However, when perfused with 15 millimolar of glucose, that's 3 times the 5 millimolar, this amount of glucose, 3 times higher, suppresses glucagon secretion. When insulin is present, the alpha cell that is juxtaposed to beta cell receive the highest insulin concentration of any target cells in the body. The paracrine level of insulin reaching the alpha cells have been estimated to between 2,000 to 4,000 milliunit per ml. That's huge. So the insulin glucagon ratio with a 5 millimolar of glucose is computed at 0.4 and the high of 7.4 at 15 millimolar of glucose. Again, this is in normal healthy pancreas. Now, let me try to explain this again through paracrinology, which is the study of normal insulin glucagon in response to glucose in the islet cells. In an isolated rat islet pancreas perfused with 5 millimolar of glucose, insulin and glucagon ratio is 0.4. At the bottom, you can see the red. When glucose was raised to 15 millimolar, insulin takes off in a dramatic spike. But look at the time length of that spike. It lasts only a minute or two. This may represent the first phase insulin response. The amount of insulin is less than 10% of the total insulin release, a small, very small compared to the total insulin release in the periphery. While it will have no effect in the peripheral metabolism, but inside the islet, it has a big insulin response because at this level, inside the islet, it suppresses glucagon release. So the very first insulin response had a profound effect on glucagon. The insulin glucagon ratio of 7.4 is high, that tells the liver to suck up all the incoming glucose and store it as glycogen. And this is normal. Now, let's see now in diabetes. Okay, now this is an animal experiment in 1984, an isolation of normal rat pancreas and perfused with the constant level of high glucose of 25 millimolar. The measurement of glucagon coming out of the pancreatic afferent vein indicated some suppression of glucagon, as you can see that. Okay? Glucagon level as low as 1000 picogram per ml. Then a potent insulin neutralizing antiserum to neutralize the high 25 millimolar effect of glucose was introduced, hoping to disarm all insulin coming out from the juxtaposed beta cell. What they found, a 150% increase in glucagon level, and lasted only after an anti-insulin was withdrawn. The story tells us that the importance of juxtaposition of beta and alpha cell is to restrain glucagon secretion from the alpha cell. So insulin from the beta cell is the control of glucagon secretion. More recent studies show that not only insulin blocks glucagon secretion, but also the gene expression, as you can see in the slides. So, to test the key role of glucagon in type 1 DM, a study using glucagon receptor knockout mice, knocking out the receptor. The first graph showed normal mice after beta cell destruction in orange. As you can see, when you measure glucose, it's a typical type 1 DM. The orange curve looking at uh, normal mice after beta cell destruction, you see a hyperglycemic effect, okay, meaning type 1 DM, okay, showing severe hyperglycemia. The green graph represents glucagon knockout mice after beta cell destruction, meaning type 1 DM with glucagon effect, okay, so no hyperglycemia. No, type 1 DM without glucagon effect, you see no hyperglycemia. Now, on the second graph, okay, is the measurement of insulin response to an oral glucose challenge. Now, they measured insulin this time. The knockout mice before and after beta cell destruction. As you can see, the orange knockout mice before beta cell destruction, you still have beta cell to secrete insulin. Okay, you don't have glucagon receptor, but you see insulin response after a carbohydrates challenge or oral glucose challenge. However, in a knockout mice after beta cell destruction and there's no insulin, you see very low or no insulin measurement measurement. You can see very low insulin level. However, now the the last graph is letter C showed the oral glucose curve of knockout mice. Knockout means no glucagon receptor before and after beta cell destruction. Okay. Remarkably, okay, although streptozotocin treated knockout mice, glucagon knockout mice, were incapable of secreting insulin in response to oral glucose tolerance tests, interestingly, the glucose tolerance curve did not differ significantly from glucagon receptor knockout mice with an intact beta cell and a robust insulin response. In other words, insulin does not directly regulate glucose tolerance in a glucagon receptor knockout mice. Now, in fact, in every species and any form of diabetes, whether it's chemically induced, immune-mediated, okay, by the use of alloxan or autoimmune, or um, in type 2 DM, in uh, uh, generalized lipodystrophy, and even in total pancreatectomy, um, there is hyperglucagonemia. However, many will question this. Many will question this glucagon-centric view in total pancreatectomy. The question is, where does the glucagon come from if you totally remove the entire pancreas? And in fact, this is the real challenge of the glucagonocentric view. It's difficult to reconcile because the question is, if you consider glucagon play a role in the pathogenesis of diabetes, so where's the glucagon coming from? Okay, so the experiment done by Unger and Orsi in mid-70s in a total depancreatized dog showing elevation of blood glucose, you see insulin level 0 and surprisingly very high level of glucagon even though the pancreas were no longer there. Where is the glucagon coming from? Measurement of gastrin vein glucagon was 3 to 4 times higher than in the inferior vena cava, so it seems that the glucagon is coming from the stomach. So here's they undertook careful research, doing electron microscopy and markers of ARPA cells. They found out homogeneous dense core of the secretory granules surrounded by halo of alpha cell found not only on the pancreatic alpha cells but also in the stomach cells. Now, when it comes to treatment of type 1 DM with insulin, the existing dogma is insulin therapy is sufficient therapy for type 1 DM. Now, we have insulin monotherapy for almost 100 years since the discovery of insulin. And we know our experience, we cannot duplicate the normal homeostasis of normal non-diabetic normal pattern of blood glucose on your left. Okay. Compared to a type 1 on your right, no amount of glucose load or exercise can move above and below the normal narrow range of blood glucose. Even in the best type 1 DM shows a pattern quite different from the normal pattern. Frequently low blood glucose causing severe hypo, while surge of blood glucose, particularly during mealtime, reaching as high as 200, 300. This is called glycemic volatility in type 1 DM. This is the pattern of life of type 1 DM, requiring multiple blood glucose determination each day in an endless chase for normal glycemia. Why insulin therapy cannot duplicate this non-DM pattern? Well, the difference between secreted insulin and injected insulin. Okay, the secreted insulin begins its journey in the islets of Langerhans. The juxtaposed secreting insulin called the juxtaposed secreting insulin cells to the alpha cells. Therefore, undiluted insulin suppresses alpha cells. Once insulin leaves the islet, it enters the portal vein. Diluted once it passes the liver, it gets to the peripheral tissues with further dilution. Compare this with injection to get the identical dose of insulin at the target level. And obviously, it cannot duplicate the endogenous effect of insulin secretion. So why not increase insulin so that enough insulin will reach inside the islet paracrine effect? However, you will only overwhelm the peripheral tissue and run the risk of severe hypoglycemia. Alternatively, one solution is if we can give a glucagon suppressor and reduce glucagon level without increasing its exogenous insulin dose and will not overwhelm the peripheral tissue and thus prevent hypoglycemia. The comparison of the itineraries and destination of secreted and injected insulin. This depicts the extreme differences between the pathways and targets of secreted and subcutaneous injected insulin. These differences may play a major in the extreme glycemic volatility that complicates insulin replacement therapy in type 1 DM. A, you can see secreted insulin, the response of endogenous insulin and glucagon to a high carbohydrates meal. The beta cell almost instantly secretes its first phase in bolus of insulin via paracrine route. Okay? The alpha cell respond to the insulin abundance by suppressing secretion of glucagon. The resulting insulin-glucagon ratio entering the portal vein is very high. This puts the liver in an anabolic mode in which incoming nutrients are taken up and are stored in macromolecular form. Insulin level in the posthepatic circulation are relatively low, with most of the insulin being bound to insulin receptors that are concentrated in the splanchnic targets. You can see B, subcutaneous injected insulin, the pathway and target of injected insulin are different. Subcutaneously injected insulin will remain at the injection site for about 10 to 50 minutes or longer. Thus, no suppression of glucagon is possible as the nutrients enter the circulation. The high glucagon level entering the portal vein will maintain fasting level of glucose production. When a large dose of insulin intended to correct the postprandial hyperglycemia finally distribute throughout the body, it will cause hypoglycemia. Thus, the roller coaster glycemic pattern may be the result of inability of injected insulin to reach its targets as rapidly as secreted insulin. Here are some of the published data looking at the level of insulin at different tissues. Highest at the islet and diminishing as it reaches the port, vein, and the peripheral vein, while the injected insulin varies with the dose given. Now, how to stabilize glycemia in type 1 DM? This is how Professor Unger proposed to stabilize the glycemia of type 1 DM. Say you have this glucose volatility pattern, then you want to reduce the hypoglycemic episodes by reducing exogenous insulin to 0.2 units twice a day, and this is in the level of mice dose. However, when you reduce insulin, okay, you may reduce hypoglycemia, but you will further increase glucagon level. And you don't eliminate the surge for the surge of hyperglycemia. One remedy is to use a glucagon suppressor, glucagon suppressors other than insulin, and perhaps then you can change and duplicate the normal glycemic pattern by using glucagon suppressor. And again, this is again by hormonal treatment. This is in a non-obese type 1 mice given 2 hormones versus just 1 insulin monotherapy. Okay, comparison of blood glucose level in a non-obese type 1 DM mice treated with 0. Unit per day of insulin or 0.02 unit per day of insulin plus leptin. Remember that leptin has been shown to decrease glucagon level. Injected twice a day. Okay, so you can see the optimal insulin curve in red and suboptimal insulin dose plus leptin, a glucagon suppressor infusion in orange. Using leptin as a glucagon suppressor leads to a disappearance of the spikes and the hypoglycemia dips. So let's look now the data on type 2 DM. Okay, now as you can see, the plasma glucagon, insulin, and glucose level in response to a large carbohydrates meal in a subject with normal and type 2 DM. You see the differences. I don't need to discuss that. And among the etiologies postulated for the pathogenesis are many. It could be genetic defect, insulin resistant, beta cell exhaustion, glucotoxicity, obesity, and even redox reaction. Although any or all of these processes are plausible and may play a causative role. There is another possibility that seldom mentioned, the lipotoxicity of the islets. Now, but recently it's more and more being mentioned, the lipotoxicity in the islets driven by excess dietary carbohydrate consumption. The slides look at the pancreatic islet fat content in diabetic-prone DB mice and lean wild-type mice. For the first 8 weeks or so in their lives, okay, diabetes-prone DB mice in blue maintain about the same amount of body fat as lean wild-type mice. The lower panel, just before the 8 weeks mark, the pancreatic islet fat content, the white square, of the DB mice begin to rise compared to that of the wild-type mice. As the islet fat increases, diabetes developed in DB mice. As the increase in fat accumulates in the islets, the morphology of beta cell changes markedly. During the first 8 weeks, okay, beta cells in the DB mice have normal appearing mitochondria and plenty of insulin granules. About 10 weeks, many of the beta cell mitochondria appear severely damaged and the insulin in the beta cell has degranulated. But does this happen in human as well? Because these are all animal experiments. Now, the graphic shows it does. No? Okay, Linkway et al. Used magnetic resonance spectroscopy to determine the pancreatic fat content in human subjects and compare it to their degree of glucose intolerance. You look at the normal weight, okay? Glucose tolerant subjects were compared with obese, glucose tolerance and obese, and glucose intolerant subjects. Okay, as is apparent, there was a substantive increase in the pancreatic fat when moving from the obese glucose intolerant situation to obese glucose intolerance. Even subjects fully developed type 2 DM, pancreatic fat, and those with just glucose intolerance have little more, if any, more pancreatic fat. Okay, so could type 2 DM be due to insulin resistant and alpha cells? It shows here normal pancreas alpha cells are relatively sensitive to insulin. Diabetes much less sensitive, as you can compare the two. Normal with 3 picogram compared to type 2 DM with a very low 0.02 picogram. Okay. So incubated normal rat islets with the level of palmitate converted to ceramide. Normal in blue and red in DBDB mice. Okay, and this predisposes to diabetes. Greater incorporation and accumulation of ceramide is the key or the culprit for the insulin resistance. Now, we go now to the paracrinopathy of type 2 DM. The graphic on the left shows the normal paracrine response to an increase in glucose perfusion in the normal non-DM animals. As the glucose perfusion in the animal triples from 5 millimole to 15 millimolar, it is accompanied by a sharp spike in insulin release and quickly tapers off. The spike lasts but a couple of minutes and represent only about 10% of total insulin release. This rapid spike hitting the alpha cells markedly reduces the secretion of glucagon. The important things to note is that it is the spike in insulin that immediately lowers glucagon, while the lower insulin level following the spike is able to maintain lower glucagon level. Now consider what happened when the glucose perfusion is tripled in the pancreatic in the pancreas of the diabetic rats. In the graphic on the right, the most notably feature is the absence of insulin spike, the first place insulin secretion, and lack of suppression of glucagon. And in fact, insulin level increase in diabetic animals to higher level than they do in a non-DM animals. But glucagon is not suppressed and continues to rise, as you can see. Now, this is what you see in type 2 DM or the same experiment. The first thing you note is the last of the first phase insulin release the spike, but the insulin level are higher than normal overall, and because of insulin spike is gone, there's no more suppression of glucagon despite the high level of insulin. Glucagon level is also high because they are insulin resistant, and that results of a low insulin glucagon ratio of 0.4 or less than 1 tells the liver don't store in the incoming glucose and continue to manufacture or synthesize glucose to keep synthesizing glucose because we are starving, even though a big meal have been just ingested. In other words, a wiring information is being transmitted to the liver, and this is why glucose tolerance is so abnormal in hyperglycemia persists. And this is the final experiment in the series. Normal mice, far left, okay, with DBDB with positive receptor, DBDB with negative glucagon receptor. Okay, these are three animals, no? Normal, DBDB mice with presence of glucagon receptor, DBDB mice with negative or knockout glucagon receptor. What are measured here are plasma insulin on your left, and on your right is glucose. For normal mice, you can see low insulin level and normal glucose level. In the middle, DBDB mice with the glucagon receptor showed increased insulin and glucose level. Okay, and the next is DBDB mice with knockout glucagon receptor, meaning mice that is diabetic but without glucagon receptor showed similar pattern with normal mice. In the middle, the DBDB mice with the positive glucagon receptor, it represents a perfect picture of insulin resistance, okay, with both plasma insulin and elevation of blood glucose. And when they injected adenovirus containing glucagon receptor to bring back the glucagon receptor, the mice developed similar pattern with insulin-resistant mice with blood glucose approaching to 600 insulin levels sky high. Okay. So this animal experiment showed that glucagon receptor deficiency prevents insulin resistant and type 2 DM in a DB mice, and injecting it back with an adenovirus glucagon receptor restore the insulin resistant. So study tell us that glucagon action is required in type 2 DM. It it also tells us that insulin resistant type 2 DM giving more insulin may not be beneficial but may even be harmful. So to summarize the role of alpha cells in the pathogenesis of type 2 diabetes, let me try to re-explain the normal paracrine effect. A, we see the microscopic islet cells, okay, of a human islet. Human islet shows an extensive juxtaposition of insulin and glucagon containing cells. Note that clusters of insulin containing cells in red are surrounded by glucagon containing cells in green, which seems to line in the blood vessels. B, demonstrate the reciprocal responses of insulin and glucagon to 20 milligrams per deciliter changes in the concentration of glucose perfusing the isolated pancreas of rat. Note the first phase insulin secretion as a spike, followed by a second more prolonged period of insulin secretion. The dotted line comprises the first phase insulin secretion high enough to inhibit glucagon release from the juxtaposed islets. C. The range of plasma glucose level in a normal individual. Even extreme calorie stress or caloric stress do not raise or lower glycemia above this narrow range. Okay. Intensive exercise is marked by a gray arrow on top. Oversized meal ingestion is marked by black arrow in the lower panel. Now, let's look at type 1 DM. This is the morphologic, parakinological, and clinical features of pancreatic islets in type 1 DM. A. The confocal microscopy of islet from a patient with type 1 shows replacement of insulin-containing cells with glucagon-containing cells in green, devoid of contact with beta cells. B. The absence of juxtaposed insulin-secreting cells, basal glucagon levels are increased, and they increase further in a paradoxical response to hyperglycemia from a carbohydrate-containing meal, thereby worsening the basal hyperglycemia. C. Even in the subject with optimal control type 1 DM exhibited severe glycemic volatility. So, morphological, paracrinological, and clinical features of pancreatic islet in type 2 DM. A. Islet morphology in type 1 DM does not appear to differ grossly from the normal islets. The juxtaposition of alpha and beta cells appear to be approximately normal. Okay. B. Despite the juxtaposition, the alpha cells are not suppressed by the hyperglycemia. This appeared to be secondary to loss of the first phase pancreatic spike of insulin release immediately after the ingestion of carbohydrate-containing meal. Without this spike, believed to be the cause of glucose-induced glucagon suppression, glucagon remains unsuppressed and elevated relative to the ambient blood glucose. The failure of glucagon level to decline during carbohydrate feeding exaggerates the postprandial hyperglycemia. Okay, the last one, despite the relative hyperglucagonemia and hyperglycemia, glycemic instability in type 2 DM is not a problem. So, with that, I would like to close my presentation on the role of the alpha cells in the pathogenesis of diabetes by showing this slide as a guide to the alpha cell course. To understand alpha cells better, it is to know and understand all about synthesis, secretions, and actions. And synthesis is there's a gene in the cells that uh, uh, that is present, which is called the pre-proglucagon genes that synthesize a large amino acid structure called proglucagon genes and there is a pro-hormone convergence on the specific tissues that convert or cut this long chain amino acid to a certain hormones, like for example in an alpha cells, it split a 29 amino acid called glucagon. Secretion, once its glucagon is released, okay, once the alpha cells, there are a lot of stimulants, okay, or inhibitors of alpha cells. There are a lot of processes that stimulate glucagon release. It could be paracrine, autocrine, neural, endocrine, etc. And the last one is action, which is quite important in therapeutic potentials, because the action is based on the receptors that are present in the target cells, in the islets, liver, heart, adipose tissue, etc. The most important is the liver in terms of glucose homeostasis or hyperglycemia as the as the effect of glucagon, and the signaling pathway and receptor called glucagon, G protein coupled receptors, and the signaling pathways. So these are important things to understand, especially when we go to the potential therapeutics. Okay. So with that, I'd like to thank everybody for listening.
Thank you very much, Dr. Ang. Can you hear me na ba?
Yeah, I'm here.
Thank you. Palakpakan po natin si Dr. Ang. So, sir, napakahusay ng pagka-deliver po ng lecture. So, we would like to thank you for that very comprehensive lecture. So,
Danny, somebody's raised his hand or have raised his hand earlier. May nag-raise ng hands eh.
Yes, merong nag-raise ng hand. Si Dr.
Ano ba? Teka, wait. Hanapin. Binaba na yata.
Binaba na. Natakot na.
So, anyway, before we start with any question, so batiin muna natin ng happy birthday si Dr. Unger. Bukas pala birthday niya, sir. Yun ang nakita ko sa lecture. Okay. March 7 ang birthday niya. So, napaka-gandang discovery rin yung ating glucagon. So, any questions po? Ayan, may nagtaas pala. Dr. Siemens Bonacqua. Hello? You may unmute, sir, para mag-ask ng question. Nakataas po yung kamay niya.
Okay.
So thank you, sir. May
questions ba?
Ayan. Yes, sir. Sino po to?
Dr. Joe.
Yes, Dr. Joe Cope.
Sir, when you say in juxtaposition of the alpha cells and the beta cells, the number of alpha cells is equivalent to the beta cells. Do you mean to say that?
When you say juxtaposition, that doesn't mean that the beta cells is equal to alpha cells. In fact, when you look at the islet cells, human islet cells, majority is the beta cells. It's about comprises about 70%. Can you hear me?
Yes, sir.
Yes.
The juxtapose is there might be 2 or 3 beta cells, but there is alpha cells that is that are in proximity to the beta cells. Now, that according to Professor Unger, the reason for that is not an accident. Okay, the reason for that is for the paracrine effect, because once the beta cell is stimulated, the insulin level secrete, and this insulin level, since the beta cell, the alpha cells is juxtaposed to the beta cell, it inhibit the alpha cells. Okay, that is the reason why. But it doesn't mean that it's equal numbers in terms of if you want to ask the numbers. The majority of the islet cells are beta cells than the alpha cells. I just want to emphasize that this is always mistaken, the mice, because these are, or majority of these are animal studies. So this is just a concept, a dogma. It has not been proven very well in human studies because it's not easy to do human studies. Okay, especially when I will explain this, especially when I go to the therapeutics. Okay, so most of these are animal studies. Okay, now there is a difference between the cytoarchitecture of a mice or rodent versus human. Okay, ang human is yun nga, yung alpha and beta, which is the two most important. I'm not saying the other islets are not important, but these are the most important in terms of glucose homeostasis. And they are, in human, they are juxtaposed to each other. Okay, so proximity. Okay, now in the rodent, it's a different architecture. Yung beta cells niya is more interiorly located, and in the mantle outside surrounding the islet cells, okay, are the alpha cells. Okay, so the question is in rodent, is there any paracrine effect? Because they still have glucose homeostasis. Wild type mice do not have diabetes, right? So there must be a paracrine effect. So if in human, if it's a juxtaposition, that's why the paracrine effect it's in effect. In effect, how about in the rodents? No, now Professor Unger has an explanation on this. He claimed that 70% of total endocrine population, okay, the glucagon cells are arrayed in the periphery of the islet. This is in rodent, so that only minority of the beta cells are juxtaposed to alpha cells. Again, this is in animal. This is in rodent. However, the intra-islet microcirculation appears to provide an insulin pathway from the beta cell to the alpha cells, meaning to say, when they release insulin, it goes to the intra-islet microcirculation that reaches the alpha cells that produces paracrine effect. So this is the hypothesis of Roger Unger. Again, the rodent, if you look at the cytoarchitecture of the islet cells, especially the alpha and beta cells, in rodent is totally different from human. Okay, but both have paracrine effect.
Okay. Thank you po, sir. Thank you, Dr. Cope. Sir, may naisip lang ako. Can we measure yung glucagon?
Yeah.
Kailangan ba natin siyang sukatin pagka nagtitreat tayo ng mga pasyente?
Sa research yun, mini-measure, lalo sa animal studies, measuring the, in fact, before the advent of a sensitive test called radioimmunoassay by Yalo and Burson, hindi nga nila malaman ang biology ng glucagon. And when Yalo and Burson were able to develop a very sensitive test for glucagon, okay, called radioimmunoassay, that's the time nag-take off ang glucagon. So they were able to find out and learn more about the biology of glucagon. But glucagon is not regularly or routinely done in the clinics. It is in research.
Okay. How would we translate that sa practice? Kung hindi naman natin siya na-measure. Puro blood sugar lang din.
And I don't know how to answer that, but the topic is just looking at glucagon as part of the pathophysiology of diabetes, either type 1 or type 2. Again, this is a dogma. This is a concept that Roger Unger, the one proposed, and he has several reasons to believe that glucagon plays a part. Okay, maybe not the major part, but it has a part, not only insulin deficiency, both in type 1 and type 2. And this I already mentioned in my slides, I think in the first few slides, and the basis, there are pieces of evidences, okay, or pieces of evidence. Number one is glucagon increases hepatic glucose and ketone production, which is the catabolic features present in insulin deficiency. Number two, the increase in glucagon or the hyperglucagonemia is present in every form of fully controlled diabetes, whether it's type 1 or type 2. Number three, glucagon suppressors like leptin and somatostatin in studies have shown that suppresses the catabolic manifestation of diabetic during total insulin deficiency. Number four, the total beta cell destruction or total beta cell destruction in a negative glucagon receptor knockout mice does not cause diabetes. Meaning, even if you have total lack of insulin, if you don't have glucagon effect, you will not have hyperglycemia. And the last one, perfusion. You saw that in the 1984 studies, animal studies, when they perfuse normal pancreas with anti-insulin serum, it causes marked hyperglucagonemia. So these are 5 pieces of evidence that I presented, that Roger Unger would like to believe that glucagon is part of the pathogenesis of diabetes. And I presented animal studies, most of them animal studies, and some human studies to back up Roger Unger's evidence.
Thank you, sir. May question po si Nine, sir. In type 1 diabetes, aside from insulin, what will be our treatment options based on the lecture? Siguro masasagot din niya.
Okay. Nines, okay, go.
Nines. Sir, tinype niya sa chat box ko eh. So yung, sa type 1 diabetes daw, sir, aside from insulin, what will be our treatment options based on the lecture?
Based on the lecture, ang gusto kasi ni Unger, ang pinresent niya is, you remember the mice animal studies na optimal insulin dose, that's one, and another animal with suboptimal insulin plus somatostatin. I'm sorry, leptin. Non-obese, leptin, not somatostatin. Okay? So, yung insulin na optimal dose, you can see the volatility of the blood sugar of the patient, of type 1 patient, mice, type 1 mice patient. Type 1 mice, okay? Yung volatility is the hyperglycemia and hypoglycemic dips. Yun ang volatility, okay, if you just use insulin. The other one, you want me to show the slides again? So that it will be clear? Or you can imagine it?
Yeah. Nice.
You want me to show the slides?
No, sir, I can imagine it.
You know the answer already.
That's my lecture.
Okay, if you give suboptimal insulin, okay, to prevent the dips, the hypos, and then you give something for the glucagon excess, then you can avoid the volatility of type 1 blood sugar levels.
Sir, why does it translate to human, giving leptin as a treatment?
They're still studying this, okay? Now we will go, you are preempting my presentation, okay? Because therapeutics will come on the last day, okay?
Meron pa kasunod na yun.
Okay. Although in the States, there is another agent, okay, that can be combined with insulin, okay? So it is combined with insulin, which is called pramlintide.
Amylin.
Pramlintide. Okay.
Yeah. Thank you.
Amylin, okay.
Yeah. Thank you po, sir. May other questions pa po from the from the board, from the screen.
Overtime na tayo.
Isa na lang, sir, last. May nabasa kasi ako tungkol sa transdifferentiation of beta cells from alpha cells. Nangyayari ba yan, sir?
So wala yun sa ano ni Unger, pero may na-encounter ako doon na yung alpha cells, sometimes you can induce it to become beta cells.
Yes.
Okay? So it's kasi in type 1 diabetes, okay, if you transdifferentiate or de-differentiate, okay, beta cells from other islet cells, okay, or develop an islet cells, no, it should not only just alpha cells or beta cells. It should function very well. And the function that they want is the paracrine effect. Useless yung makadevelop ka, mag-transdifferentiate ka sa animal,
maging alpha, ay maging beta yung alpha.
Implant ka, tapos may beta cells ka, pero pag hindi sila may with correct wiring, wala rin. Okay?
Okay. Thank you, sir. Siguro, ngayon lang natin nakita uli si Dr. Ang, ano? Nakakamiss yung face-to-face kasi pagka face-to-face, meron niyang baon joke.
Oo.
May baon ba kayo?
Alam mo, mas madali na ngayon yung yung PowerPoint, yung bagong edition nila. Kasi I've been having problem with the previous edition of PowerPoint kasi pagka record ka, napuputol. At saka hindi mo nakikita yung ito ngayon kasi may bago, nakikita mo yung pwede yung picture mo pumunta ron eh. Pwede yung picture mo makita sa slides. Lang ang caveat doon, minsan natatakpan yung ibang slide, yung ibang part ng slides, at saka nakikita na mawalan na ako ng buhok. Yun ang caveat doon. Okay.
So, yun ang joke.
Yung buhok.
Buhok.
Yun ang joke doon.
Thank you. So, palakpakan natin ulit si Seth, si Dr. Ang. Thank you, sir. And hope
so I can disappear,
in the... Hindi, ha?
I can disappear.
See you sa mga susunod pa kasi may 3 pa tayong natitira, sir. So, next week, susunod pa.
No, I can disappear now.
Yes, sir. Thank you po.
Okay, bye-bye.
Thank you, sir. So, indeed, they are sending their congratulations lecture po. So, without further ado, we will go back sa kay Kuya. Yan na siya. Oh, sir.
Naputol ako kanina eh. Pero kailangan tapusin muna natin yung highlight na lecture ni Dr. Ang na very, very informative na hindi dapat nating makalimutan habang sinusundan natin yung storya ng alpha cell dito sa 4 na meetings natin. Okay? Pero dahil sa pinutol ako kanina, kailangan tapusin natin yung lecture natin, no? And i-share ko uli
Yes, sir.
Kung saan ako naputol, babalikan natin yon kanina. Para doon sa mga hindi nakahabol kanina, no? Nawalan ako ng internet nung pinag-uusapan namin yung mga proofs na ang metformin makaka-prevent ng progression to type 2 diabetes. Doon tayo naputol eh. Yes. Pagkatapos nun, malapit, mahaba pa pala, no? Nasa kalahati pa lang pala tayo. Pero bibilisan natin, ha? Kasi importante dito yung main message of IGT, pre-diabetes, IFG, sa mga obese, no? Para maging diabetic sila. No? Doon lagay natin yung slide. Yan. And yung outcomes nga, no? Sa intensive lifestyle, may 57% reduction, pero sa metformin, meron pa ring reduction. Sabihin, sa mga hindi makapag-exercise, if you take metformin, there will still be 31% reduction. And that is significant. If you follow them up, no, sa UK PDS, sa US Diabetes Prevention Program, no, of diabetes was still reduced even after the trial. Basta't tinutuloy nila intensive treatment or tinutuloy yung metformin metformin therapy. Now, furthermore, no, yung sa 15-year follow-up, yung latest na report, no, 15 years na after the UKPDS, no, meron pa ring reduction sa progression ng diabetes. So this is the proof, the evidence is getting to be greater and greater that metformin reduces the development of diabetes. And that is whether in men or in female. Because of that, sa American Diabetes Association guidelines, sa kanilang recommendations, they have already included metformin for the prevention of diabetes in patients with IFG, IGT. Patients usually less than 60 years of age, BMI, that is obese or even overweight, pati mga women with prior GDM. And this has come out many.
Hello, sir.
No? Sa IST, matagal na namin ginagamit yan eh. About 30 years ago, nagsimula na kami. So what would be the dose of metformin that we give in the trials we follow? No? It's 850 milligrams 2 times a day on top of a weight loss of something like 7%. So it is advocated that if you want to prevent diabetes, you start early. Sa kaso nga natin, you start now. But let's follow up this case, no? Kasi if this patient went back after a few years, when she was lost to follow up, no? But when she came back, diabetic na siya, no? Na hindi niya tinuloy-tuloy yung gamot niya. Pero claim niya, continue pa rin medications, but probably because of genetics, no, nagkaroon pa rin siya ng diabetes 5 years later. No? Weight loss of 4 kilograms, at namayayat siya, tumaas ang blood sugar, pati hemoglobin A1C is 8.8. So what would be the recommendations when this patient is managed? This is the latest guidelines sa management ng hyperglycemia and diabetes. And as you can see, it is based on evidence. That is why it is earlier on, no, recommended to see whether patient has established atherosclerotic cardiovascular disease or CKD. But this patient of ours does not have that. No? Normal ang kanyang cardiovascular status. No? So, the patient without established heart or kidney disease. But the patient is losing weight, so she is not, there is no compelling need to minimize dito pala compelling need to minimize weight gain. No? She does not really complain of hypoglycemia, so we can actually use add a DPP-4 inhibitor, SGLT2, or a thiazolidinedione. No? But if an issue is caused, no, you can see that the first choice would either be sulfonylurea or the thiazolidinedione. But in this patient who is rapidly losing weight, we would probably choose not a thiazolidinedione if cost is a major issue. But if you go back to this case, no, her hemoglobin A1C is 8.8 now, and we want to bring it down to a bigger degree. So I would rather add some, be more powerful, and in order to be more in order to prevent loss of compliance and in order to have more adherence, perhaps a fixed dose combination would be better. We have a fixed dose combination of metformin and glibenclamide, 500 milligrams of metformin and 2.5 milligrams of glibenclamide, which is a sulfonylurea. We gave this to our patient that afforded quick normalization of her blood sugar because it's a powerful one, it's a powerful combination, and the effects add on to each other. They are complementary. They have complementary effects. Furthermore, the preparation of glibenclamide in this fixed dose combination, which is glucovans, is prepared in graduated particle sizes. There are small granules of glibenclamide. Then there are large granules, and in between are different sizes of granules. And this has very important effects. If you give the normal glibenclamide, no, it will follow the blue line, the blue curve, no? And this causes a lot of hypoglycemia. But the new technology that has been incorporated into the tablet that has the uh, the fixed dose combination allows the glibenclamide to have a that will cause less hypoglycemia, and that is why it is more safe and affords more benefits to our patients. In fact, while others think that the sulfonylureas will be gone from the market, many doctors still believe that the sulfonylureas will not be out of the market because it is very, very available, it is very affordable, and it is very safe and effective. So if you go back to the latest guidelines in the treatment of hyperglycemia, look at it very closely. The sulfonylureas are not really taken out of the guidelines. It is still there, even in patients who have established cardiovascular disease or CKD. If they are not controlled with their recommended newer drugs, you keep on going down the line and you can see that the sulfonylurea is still there, whether the patient has atherosclerotic cardiovascular disease or if a patient has CKD, you can still see their sulfonylurea. Even in patients who have a compelling need to minimize hypoglycemia, you can still see the sulfonylurea there, but you have to be very careful in giving sulfonylurea. In patients who are whose issue is weight, you can still see the sulfonylureas there. There, you can still see, but be very careful. And if the cost is the major concern, you can see sulfonylurea is actually high among the choices. So when you go back to your practice, do not forget the sulfonylureas are still there, and it can be combined with the drugs that are recommended to treat patients who have certain factors present in them. So I think this is our last slide. Do not uh, do not forget, no, that this the sulfur the that that the fixed dose combinations do afford the benefit that the patients will improve compliance, and at the same time the combination of the sulfonylurea, glibenclamide, and metformin in this fixed dose combination has very different effect when you give it as a separate tablet. That is my last slide. So in spite of being cut off at the middle of the lecture, thank you very much for listening and staying with us. And I would also like to thank Mark. Thank you very much, Mark, for being our partner for our lecture series. Thank you.
Thank
Thank you,
you.
Dan.
Thank you po,
Salamat din
sir.
po.
Thank you sa ating partner for this night from Merck Incorporated, the maker of Glucovans, Glucovage XR, and Kasama na rin partner nila ang Invocan. Okay? So thank you. Are there any more questions sa ating dalawang speaker for tonight? Okay. So indeed, this is a very productive lecture. So very interesting, napaka-fruitful ng ating gabi ngayon. And with that, kindly please turn on your camera pagkatapos ito. So we'll be meeting again next week for our episode 2 of the PSD Select 2 series. Okay? So pa-on na lang po ng camera natin for your attendance. Lynn, pakuha ng picture. So thank you lahat po sa mga nag-attend. So 4 na beses pa, and soon siguro po marami pa tayong gagawin. And remember po yung video nyo po pag nakapagpa-vaccine na po kayo, sabihin nyo lang po, send nyo po yung inyong video.
Lahat ng nagpabakuna na.
Meron
gawa kayo ng ng video. 5 seconds lang.
Oo, sino na ba ang nabakunahan na dito? Meron na po ba? Kay Kuya.
Si Kuya lang.
Oo,
Ako pa lang.
Malapit.
Ako pa lang.
Ako next week pa, ma'am.
Next week po.
Next week pa yung iba. Lalo na yung mga nasa probinsya. Next week pa ang dating ng box. Okay, Tita Rosman. Hello.
Hello.
Si Wewet noon, nagbabakasyon na si Wewet.
Ayaw akong turukan. Hintayin ko daw yung Astra. Senior na daw.
Senior.
Waiver. Pero mga senior na gusto nila mag-sign.
Waiver yata, waiver.
May waiver.
Hindi ako pwede. Ayaw akong ayaw pumayag ng ID namin eh.
Ayaw pa. May iba pa rin ang opinion.
Paano ba
Hello.
1, 2, 3.
Okay na, Lynn?
Yes,
Yan.
Thank you po.
Thank you.
Sabay kong nabakunahan si Dr. Ray Rosales.
Si Ray, tapos na rin.
Una Sinovac sa St. Luke's?
Yes, Sinovac. Sabay kami ni Ray kahapon.
Masakit ba? Masakit?
Nakangiti pa nga si Ray nung nakita ko